Good afternoon. Thank you for the invitation to speak at this meeting, and I'm very pleased to be able to share my experiences with near-patient diagnostics for COVID-19 in the UK. So to understand the place of diagnostics and how to interpret results, we need to really go back to understanding the phases of COVID-19 disease. Of course, early on, you have the infection event in the upper airway, which leads to high levels of viral replication in the nose and throat. And this then leads to spread of the virus into the lower tract in a majority of cases. So at this stage, of course, your detection of virus in the nose and throat is high, and that is why we have been using nose and throat samples for most of the epidemic. But as time goes on, after the first week, the levels of virus in the nose and throat start to decline. They either shift towards replication in the lungs if disease is severe, or they may be cleared altogether. And at this stage, after a week, this is typically where IgM antibodies and IgG antibodies start developing in the peripheral circulation. And this is what you can then detect. And therefore, the host inflammatory response coincides with this. Of course, you have monocyte activation and macrophage inflammatory responses that are detectable in tissues that characterizes moderate to severe disease in this condition. So we're interested in rapid nucleic acid testing or rapid diagnosis for COVID-19. Why are we interested in this? Well, it's fairly obvious, of course, to everybody. The RT-PCR laboratory tests are highly accurate, but unfortunately during the first wave, because of the sheer numbers of tests that needed to be done, the turnaround time was greater than 24 hours in many cases, and even longer when the system was stretched. Of course, when you have a patient coming in with suspected symptoms, you need to make a diagnosis quickly because this disease looks like many other diseases and we need to differentiate them because of infection control purposes. So we need a rapid triage, which means to make the diagnosis quickly, and then movement from the emergency department into containment areas, either high-level containment or in terms of a side room, or cohorting if there is a strain on the numbers of side rooms. So you need a quick result. And of course, we were having many new infections in the hospital. We also had nosocomial transmission, and now we have a second wave sweeping Europe. Of course, we need to avoid nosocomial transmission at all costs. The hospital is a place where we need to be optimally managing people with moderate to severe COVID-19, and any nosocomial transmission, of course, severely compromises our ability to do that, whilst setting up transmission chains that may be difficult to terminate. And these two papers demonstrate this. So I'm going to tell you a little bit about the Samba assay, which stands for Simple Amplification-Based Assay. It relies on isothermal amplification by transcription-based amplification. And this means that you don't need cycling, and the technology is much simpler. And initially, this test was designed to monitor HIV viral loads in fingerprint blood in sub-Saharan Africa. And so this platform has been around in many forms for the last decade or so. And therefore, the advent of the SARS-CoV-2 COVID-19 epidemic prompted the manufacturers to adapt the test to detect nucleic acid from SARS-CoV-2. So they designed primers in ORF1AB and then the NORF open reading frame. And this test can give a result in 90 minutes. As you can see in the machine here, it's a sort of size of a coffee machine or a small coffee machine. And it takes one sample at a time. And of course, 90 minutes is the turnaround time of the test. So here are some data on the performance of Samba II in the preclinical stage. You can see here that using synthetic SARS-CoV-2 RNA, the limit of detection was established around 250 copies per mil. And when we tested stored VTMs or viral transport medium in the diagnostic laboratory, you can see that on the right-hand side that the sensitivity was around 98% with a specificity of 100% versus the standard RT-PCR set up by Public Health England in our laboratories. So excellent performance in the preclinical and stored sample stage. But of course, we needed to know whether this test was as good as the standard lab test in patients coming through the front door with fresh samples. And therefore, we set up in record time an ethically approved prospective evaluation of rapid care, point of care testing for COVID-19 to measure the diagnostic accuracy of two tests. First of all was the Samba SARS-CoV-2 nucleic acid test. And secondly, we tested two different point of care finger prick antibody tests for the ability to make a diagnosis. And I'll talk about this a bit later. So in this study, the inclusion criteria were adults presenting with symptoms of COVID-19. They could have had clinical or radiological evidence of pneumonia, an acute respiratory distress syndrome, a temperature of greater than 37.8, or an influenza-like illness, or any respiratory symptoms with acute onset. And later we adapted the inclusion criteria to include anosmia and other suggestive features of COVID-19 as they arose. So in the study, we assessed 178 patients for eligibility, and 158 of these met eligibility criteria, and 149 of these were included in the final analysis. Of course, this was carried out during the first wave. During much of April is when this study was carried out, and it was done at Cambridge University Hospitals Trust here. We found, as you can see here on the right, that the Samba assay was associated with a much faster turnaround time, as shown in this Kaplan-Meier analysis, with a mean turnaround time of 2.6 hours, as opposed to 26 hours for the standard laboratory test. And remember, two swabs were taken in parallel in these individuals, one for the Samba test and one for the RT-PCR test. The concordance for the test was greater than 98%, with a Cohen's kappa coefficient of 0.96. And in the study overall, 21% tested positive. That's 1 in 5 tests. So we showed, obviously, a much faster turnaround in real life, which was very important because this can be affected by many different factors that we wouldn't necessarily envisage when you do a preclinical study. So importantly, we showed it was much quicker. And then we had the opportunity uniquely to implement the test straight away. Because as soon as we had finished this validation study, there was a huge backlog in RT-PCR testing with a turnaround time of something like 4 or 5 days due to a number of different laboratories in the UK sending their samples to us. And therefore, we had pre-ordered 20 machines in anticipation of this surge, and we were able to start using them in full-time operation to replace the laboratory for testing in the hospital, which was a huge task, and in many ways it was a huge risk because this was a new test. So this enabled us to do a real-life evaluation of the Samba test, and this is really remarkable in many ways. And so we compared a 10-day test period before and after the introduction of Samba because of these conditions. In this graph, you can see the results of the implementation. We have a system of triaging patients in the hospital in terms of whether they are high, medium, or low risk for COVID. Red is obviously high risk, amber is medium risk, and green is low risk. You can see that on the left, before Samba was available, we had large numbers of people in the amber, the orange area, 40% where we weren't really sure, and half of patients were in the green area, category, with 10% in the red high category. The important thing here is that people in amber were the ones who needed to go into specific side rooms and isolation rooms, which are in short supply in our hospitals. You can see after the Samba test was introduced, on the other hand, that this amber group shrank to 12% because we were able to make a positive or a negative diagnosis in our patients. And this saved valuable side rooms that were otherwise going to be used for these amber patients. So this had an immediate impact on side room availability. In addition, we were able to move patients much more quickly, and this graph shows you where patients went to. You can see here that the number of patients needing a side room went from 30% down to 20% because we were able to make a diagnosis of either them being positive for COVID, so that they could go to a cohort bay, or they could go to an open ward where there were COVID negative patients. In this graph, we can see on the left the turnaround time in the clinical validation phase, and here you can see the times were a little bit longer because we were not in any longer in a clinical trial environment as before. And here we had a 3.8-hour turnaround time for the Samba test versus 36 hours for the standard lab test, and this was statistically significant, as you can see. And more importantly, really, in terms of implementation science, you can see that the time to definitive water move was faster in the Samba arm of the study, suggesting that Samba could have real-life implementation improvements. Here's a graph of the 1,000 patients or so who were tested after the Samba implementation. This gave us a really good opportunity to know which kinds of patients were being tested. And you can see the main reason for being tested with the rapid point of care test was admission, triage, and placement. There was also 10% who were symptomatic within hospital with new symptoms and who needed to be tested. Of course, we were discharging patients and they needed to be shown to be negative before they were discharged. Otherwise, we would end up obviously seeding the epidemic in nursing homes, for example. And of course, pre-operative testing was critical because of the fear of COVID-19. We had to show that patients were negative before they went for surgery. And in many cases, there was urgent surgery planned and we couldn't wait for a standard lab test. So that's the first part of the talk. The second part of the talk now we'll move towards the need for dual testing because of this problem of what has been called a false negative PCR. I don't really like this phrase because there's nothing wrong with the PCR. The test is detecting what it is supposed to. But the problem, as I said earlier in COVID-19, is that the second phase of disease is associated with a loss of virus from the nose and throat and an increased inflammatory response that can be detected by detecting antibodies. We have to develop a gold standard for diagnosis of COVID-19. So we decided we were going to combine nucleic acid testing and antibody testing to make a composite endpoint. We used serum ELISA to help validate this. And then we developed a serum neutralization assay using pseudotyped HIV particles bearing spike protein on the surface. And therefore, with this gold standard, this is the graph just showing you how we did this. We used pseudotyped HIV, and these are a variety of transfected cell lines on the right-hand side, just to show you can get infection with these pseudotyped particles. And then this is the basis for neutralization assay, which involves serial dilution of your serum and addition of standard amounts of pseudovirus, and then you read out relative light units because there's a luciferase reporter in that virus, and you can then measure and quantify the degree of inhibition by serum. So the second part of the COVID-X study was to test these rapid point-of-care finger prick tests for IgM and IgG to see whether we could increase diagnostic sensitivity in patients coming in through the front door. These are some data just showing you the range of serum dilutions and neutralizations gained from patients. On the left are the positive patients in the study who are positive for COVID-19, and on the right are the negative patients. You can see there's a clear difference in neutralization ability and the validation with ELISA shown on the right. So here's the headline slide. Basically, you can see that if you use Samba alone, and in other words, the point of care nucleic acid test, you only have an 80% sensitivity. You're missing 20% of cases. But if you use serology test in combination, you can get to 95% sensitivity. With the combined, so 100% sensitivity with the combined test with a 95% specificity. So this is using the Shaw screen point of care antibody test. Above here in the middle, you can see the results for a different point of care antibody test called COVID-X IgM and IgG, and it performed quite well, but it was less specific, and this is a bit of a problem. So what about the D614G mutation? We know this is a spike mutation. The question was, could the POC antibody test detect IgG to this variant? You can see here that this is a list of patients and their sequence alignments in the spike protein. You can see that the majority of them had the G at position 614, and then we needed to evaluate whether the point of care serology test could detect this variant. You can see here that they get very nice correlation between the band intensity on the point of care test and the neutralization here in figure B. And this is a very nice correlation you can see on the right-hand side. So this is a table showing you that the patients who tested positive for D614G by deep sequencing were detectable by antibody tests if they were neutralization positive. So this shows that the point of care tests can detect 614. So in terms of implementation of combined testing, I've shown you in a trial setting that we can reach 100% diagnostic sensitivity with 95% specificity. We have now used it in 150 patients, but of course this was in the low incidence period. We only had 4 positive results. but we were able to show during this period that both point of care tests for serum antibodies did have greater than 98% specificity. And that is very, very important because people are worried about specificity of point of care serological testing. So the conclusions are we can use near-patient nucleic acid testing for increasing efficiency in hospital. Samba II is the platform that was first developed for this because it had a head start. It had been used in Africa for HIV, and therefore it was known to be robust. We did the first clinical trial showing sensitivity and specificity in a real-world setting, and this is the first in the world, I believe. And this machine is now being used in over 100 sites in the UK with amazing results. We've also shown that antibody point of care tests could be used to increase your diagnostic sensitivity at the front door in place of things like CT scans, which are expensive and time consuming. A point of care antibody test would be much more reliable. Of course, we have the problem of not being able to detect past infection, but I think that with further research, we can get around this. I'd like to end by acknowledging the members of my team and the individuals named in this slide for all their collaboration and efforts in bringing the rapid testing to the British public.